Hello, everyone, and welcome to our Permanente Live webinar, Keeping Patients and Clinicians Safe from Harm. I'm Dr. Steve Perotti, Executive Vice President of the Permanente Federation, which is the national leadership and consulting organization that represents the interests of the Permanente medical groups. And I'm really so pleased that we're talking about this subject today because safety really is a bedrock when it comes to healthcare. At a most basic level, it is fundamental to the functions of medical practice and a healthcare system. It is also at a higher level part of our calling to provide healthcare that we would want for our own families and for our communities. And increasingly, it is recognized as a contributing concern for why people stay or leave healthcare as a career. It can be a source of inspiration, or in some quarters, a source of moral injury. And as an industry, we have been on a multi-decade journey to raise awareness and to actually set and activate the principles of what would be expected for highly reliable organizations. So I am looking forward to and glad that we are joined by an esteemed guest, Dr. Marcus Schabacker, who is the president and CEO of ECRI, which is a patient safety organization known for its medical device evaluations, hazard alerts, and evidence-based guidance to create a culture of safety that stops preventable harm against patients and clinicians before it occurs. ECRI is federally recognized and is an independent nonprofit and is a well-established leader for healthcare risk and the safety community. And I'll just say, Kaiser Permanente and ECRI have had a long, storied relationship working together. So Marcus, it is a real pleasure that you are with us today. And I want to sort of kick it off with an initial question. I mean, we as an industry have been, and your career, I think actually spans this. When the Institute of Medicine first published To Err is Human back in 2000, it was sort of a clarion call to action. Can you talk a little bit about what progress we've made? What remains to be sort of realized in that, initial report that we saw back in 2000?
Yeah, Steve, first of all, thanks. Thank you so much for having me, having ECRI here with you. It's truly a pleasure and an honor to be here with you to discuss this most important topic, really, when it comes to healthcare. And to your question, while we have made some progress, much left to be done. And we just had a recent study who used the Bates-Annal published in 2023, which used the methodology of the initial To Err is Human study and found that 1 in 4 patients admitted will experience a adverse event, and 25%, or another quarter of those, are preventable, which basically keeps us at the same number the initial study called out, which is about 100,000 preventable deaths per year. So now I'll let that sink in a little bit. 100,000 deaths preventable per year. Just to give the audience an idea of what that means. And we all heard, 737s max don't take off because the window blow out and no casualties. If we translate that number into airlines, it would mean that a 737 MAX 9 crashes every single day of the year with no survivors. And so that's a shocking number. And from that perspective, yes, lots remains to be done.
So Marcus, that is a great way to dive into this. And just want to notice everyone that is joining, and we're so thankful that you find this topic to be so important. You can join the conversation as we sort of progress here on social media using the handle #PermLiveLeadership. We're also live on LinkedIn, and we want to thank all of those who are joining us on that platform. And then the other reminder, as we have our conversation, is that we want to encourage you to submit your questions for our guest and use the Q&A function, and we'll make sure that we get to some of those questions towards the end. So, Marcus, you referenced the airline industry. And, I'm thinking about the, recent news, early 2024, And it was in the news in terms of the culture of safety, I would say, that has permeated the airline industry, and a lot of questions about what maybe has gone wrong. And I think about healthcare, and in the context of what we were just talking about, in many ways, the airline industry is going through a reckoning. Do you think healthcare is going through a reckoning, or is there a reckoning to be had?
There's a reckoning to be had. I think we're not quite there yet. I think we haven't been quite as shaken up as maybe the airline industry has yet. And the reason for that is these events are not as public, are not as visible. They don't happen in one place all at the same time with media focusing as there's a burning plane somewhere. It's happening every single day somewhere to someone. And that's where it becomes more difficult to draw the attention to it. We as an industry, as a healthcare industry, are certainly at some crossroads. I have seen more change maybe in the last 3-4 years than I have in my 35 years prior in healthcare. And some of this is going to force that reckoning. But at the end of the day, if the leaders in healthcare, and this is what it took in aviation in early 2000, is everybody came together, the airlines, FAA, the airports, the manufacturers, and said, we want to have a zero harm, a zero casualty policy. And since 2009, there's no casualty in commercial airlines in the United States. We as a healthcare industry need to get to that same point. Preventable harm is not acceptable. We want to have zero harm. You and I, we both swore an oath. And that oath as a physician, as a clinician, is to do no harm. And what do? We're harming patients, not deliberately, but preventable every day. So we need to do more. And I'm really, what ECRI and many others, and I think this is the promising thing, is it's getting more attention. So we're getting there, but it's not quite there yet as with the airlines.
You know, it's interesting, Marcus, when you bring this up in the context of the airline industry and needing to get people together and groups together. What does that look like for healthcare? You know, healthcare's, you were referencing how it's transformed. And the transformation, I think about, over a career, and the training that individuals have received, where it's, the individual is supposed to be responsible as opposed to a team. And nowadays, with the complexity of care, whether it's ambulatory or inpatient, you need a team. So what do you think convening looks like today when it comes to improving safety?
Well, first of all, I think it's really the recognition and the acceptance that where we are is unacceptable. And that's number one. Number two is then to really say, okay, we want to do we're taking a systematic approach. And that systematic approach has really 4 components. It's not something ECRI invented. This is something high-risk industries like aviation, military, nuclear power have long used. Total system safety needs leadership. It needs a culture of zero harm. It needs to involve the patient and their caregiver. It needs to have an agile learning system where positive behaviors, positive learnings are reinforced, and where near misses or misses are identified and then amplified. No shame, no blame culture, but the issues need to be addressed and then fixed. And lastly, and most importantly, is really that the workforce, the entire workforce, the nurses, the technicians, the physicians, the administrative part, the janitors, are part of that whole, that team base where everybody has a voice and everybody has signed up and feels safe for promoting safety for the patient. That's what it's going to take. In this total system approach has been proven to be very successful. We just need to apply it. We don't need to reinvent the wheel.
I really like that. And I mean, it's really getting to, our people, right? And speaking to our people. And you were referencing, I mean, in many ways, it's a silent epidemic within healthcare that these injuries are happening day in and day out, and yet it's normalized. So speaking up is so important. Um, I was struck by one of the priorities around safety, for 2024 with ECRI, which was specifically focusing on the workforce and workforce burnout. And I'm interested in hearing a little bit about why did you pick burnout? And that's not necessarily been in the lexicon, of safety in the past. So maybe talk a little bit about that.
Yeah, I think the issue of workforce burnout, and this is equally relevant for physicians, nurses, technicians, and others, anybody who interacts with the patient, has a one-to-one correlation to safety. And if you think about if you are stressed or if you have just finished a double shift and now there's an emergency, or you come out of a night shift and you have to perform another surgery, that puts a lot of emotional stress on you. And if we have this culture where we have a blame culture, where the event a couple of years ago with the unfortunate and deadly administration of the wrong drug, and the scrutinizing and public flogging, so to speak, if you allow that word, of the nurse, instead of looking at it from a systematic perspective, what went wrong from systems perspective, rather than trying to individualize the mistake. That all creates this uncertainty. This creates the additional tension that creates the stress. Staff shortages creates stress, which then leads to anxiety, it leads to depression, it leads to fatigue, and that automatically then leads to potential mistakes, which then causes even more stress, right? And brings the person down who came to healthcare to do good, to help, to provide safe care. And they're put often into a position where they can't do it because we don't have enough staff. We don't provide the necessary training, the simulation. We don't have a learning system which helps us to stay agile and react to things near term in real time. So we really need to change our approach holistically.
You mentioned with the workforce, and sometimes you'll hear, well, we can solve that with technology. We can automate processes, standardize processes, put forth best practice alerts. We've implemented a lot of those things at Kaiser Permanente. I was struck by ECRI's focus also with the latest recommendations around technology. And you were referencing how rapid things are changing. I mean, think about it. 10 years ago, we were talking about how proud we were to be implementing an EHR that's uniform and whatnot. And now, I think in the last 3 months, I've seen, I don't know how many different articles about AI and versions of AI, whether it's generative or ambient, et cetera. From an equity perspective, what's the promise? And then what's the potential issues that we need to be looking out for?
Yeah. Well, AI, I think, has the potential to truly revolutionize on how we conduct medicine. Just to put it into perspective, right? The human brain is able to cognitively to compute about 4 variables. In today's diagnostic world, we often are confronted with 20, 25, if you include genome analysis, even more variables, which our brain simply cannot compute. And so we're reducing it down to that 3 or 4, which we then can work on. AI can help if used correctly, if developed correctly, if validated correctly, to reduce that number of variables to something which we then act upon. And so that's where the promise, but that's where also the danger of that new technology is. And so where we see the biggest problem with AI in particular is, do we understand as a user, A, that it is AI, B, that how was it developed? What algorithm went in there? What was the training pool of that algorithm, or is the continuous training pool? Is it adequately diverse in its development when it comes to patient population, when it comes to disease stages, when it comes to ages, when it comes to gender, when it comes to race, and so on? Because we've seen that in the past not happening, and therefore introducing an automatic bias, which then will potentially get aggravated depending on where you and how you're using it. And then lastly, when we validate this, can we get enough real world experience to actually make sure that what we think the AI is doing is actually accurate, right? So, and with increasing complexity of that world, and increasing complexity of what's going on in the black box, that becomes more and more difficult. So there's a call out to regulators and to developers and manufacturers and saying, please do make sure that when you develop those tools, which can be tremendously helpful if done right, make sure that you have that you're aware of the biases you're introducing, that you try to stratify for that you are making sure you get enough medical insight into that technology development, because there's no disrespect to our medical profession, but we're not, most of us are not code writers or algorithm developers. So there's the tech people who do the work behind the scenes, and they need to be guided not just by one medical expert who has but it needs to be based on evidence. We pride ourselves to be one of the only non-academic evidence-based centers, so we know a lot about evidence. But does that clinical evidence really get included into the development of those AI? That's a big call out. There's the big danger from our perspective, in that these biases which get introduced early on keeps on perpetuating and getting worse and worse over time.
So Marcus, I'm gonna pull on this thread a little bit here, because you're raising a really important question, and you referenced, there's a bunch of stakeholders involved with this, right? So it is not just the healthcare industry. You've got information technology, you have regulators, policymakers. In fact, I think I could cite for you any number of federal and or state level sort of activity right now in terms of trying to set the rules of the road for AI in general, and then for healthcare in specific. What do you think good looks like here, coming up into the future, right? Where do we as physicians, as clinicians, insert ourselves into this process? Do you think it's upstream? Do you think it's during development? Is it post-development? Is it validation? Is it all of the above? And I'll insert one thing. I'm finishing up a book that was written by Eric Topol around AI and medicine and its promise, and introducing back into hopefully medicine more humanity, so that physicians and clinicians can spend more time at the bedside as opposed to locked in an EHR. So I'm curious, what do you think that looks like?
So it's all of the above, right? The clinicians need to introduce themselves early on. We need to, again, take a systems approach. We need to think about the human factors of that approach. The human factor, we haven't talked about human factors yet. That's in healthcare, that's a relatively new concept. So clinical human factor engineering. Would love to spend a minute there if we can. But so the understanding in which scenario that AI is going to be used. Is it truly a decision support tool, or does it quickly become a decision-making tool? And if that's the case, there needs to be way, way, way more stringent regulatory approach. And so the clinicians need to be left, right, front, and center back in this process: development, validation, usage, post-mortem evaluation. So we need to have ongoing evaluations. What is happening with it? And I'll just remind you, so you could talk about EHR for a long time about what that did or didn't do for healthcare. It certainly didn't increase patient clinician time, right? It cut that dramatically. But think back when we introduced computer tomography, CT scanning. We started treating a lot of things which we saw and thought were abnormal until we realized it's actually not a pathology. It's a variance of normal. And and now we know that better, and we, not over diagnosing, over treating. With AI, that risk is even more so, that we identify things, and then the question, so what, right? Is this a pathology? Is this truly where we need to intervene? Or is that something which is just the variance of normal? And I think AI can help in that if it is developed the right way, if it is validated the right way, if it's tested the right way, and if it is reevaluated after it has been used for a longer time. Because as you know, as a practicing physician, we often learn, sometimes years later, that some of the things we believed we were doing good were actually harmful. And depending on how often that technology is used, we might see it only after a longer period of time. So if you have a device or an AI which is used 10,000 times a year, it takes a while to show the 1 in 100,000 or 1 in a million adverse events. And so that's why we need to be extra diligent there. We cannot take the physician, the clinician, out of the equation. I no think matter what technology.
You are so right. I mean, this has to be informed by clinicians and clinicians that are actually practicing at the bedside, right?
Yes.
Or now increasingly at the home side or wherever it is. And actually, let me sort of pivot here in terms of it's related to technology, but it isn't, which is, and I know ECRI has an interest in this and a focus when it comes to simulation and the use of simulation to, prepare for, anticipate, and learn from each other as teams. And in addition to that, the opportunity to introduce technology to enhance that, whether it's virtual reality. And so I'm interested in sort of where you think that needs to go from an industry perspective when it comes to simulation.
We can't do enough of it. It's never going to replace the hands-on training and experience. I grew up in a time where do one, see one, teach one. See one, do one, teach one was the mantra, and it talked about burnout earlier. It caused a tremendous stress on healthcare providers, clinicians, because they were just not equipped and this was not just a figurative speed, that was literal. They showed you once on how to do a suture, and the next time you did it, and then you taught somebody else. So, and suture is probably the most benign example I could take here. And I grew up as an anesthesiologist and intensive care specialist, and anesthesia was one of the earliest disciplines where simulation was actually an accepted teaching tool, even in the 90s. And so the simulation labs popped up and were more frequently used. Any other high-risk industry is using simulation as the key tool to improve safety for the employees, for the workers, whoever's on the receiving end of it, if it's aviation, military, whoever. Simulation may be in connection with virtual reality when and if appropriate, but simulation and repetitive training, and then added by things like team-based approach, checklists, other cognitive aids which help you deal with situations you're not dealing with on a day-to-day basis. We need to build that muscle memory particularly for those things which don't happen every single day. And, again, anesthesia is a great example. Malignant hypothermia, one of the most catastrophic events in anesthesia, very rarely. But when it happens, seconds matter. Truly, seconds matter, and you need to include the entire team, from the surgical team, your anesthesia assistant, the nurses in the room, to get that under control. But if you don't practice that, if you don't dry run this, if you don't have your checklist of what to do and where to get the meds, if the meds are not ready at the bedside, that patient will die. So that, we cannot overstate the importance of simulation in connection with hands-on training, in connections with, cognitive aids.
Thank you, Marcus. And I just want to remind our audience to please submit your questions using the Q&A function. We're going to be getting to those in just a second. Marcus, you earlier, in the context of AI, touched on the topic of bias. And certainly there's a lot of concern when it comes to the application of that particular technology and being able to understand and monitor. But to be honest with you, some of the inherent bias that we're worried about in terms of being introduced with an AI is that the AI is actually taking data that we've already put in to the EHR from our prior shared experience, which I think what we're saying is potentially inherently biased. So that is an interest of ECRIs, and it's called out specifically. What do you think we need to be doing to be more situationally aware of that potential inherent bias? What do we do to correct for that? And let's take AI out of the equation. Just the practitioners ourselves. So what should we be doing?
Steve, the biggest problem with health inequities is that it is not generally accepted that it exists. That's the very first step. We need to all look into the mirror and say, health inequities are real. Now, I'm not saying anybody goes to their job in the morning in the hospital or in an outpatient center or anywhere and saying, I want to treat XYZ person differently today than I treat anybody else. But we all have implicit biases. Some might have even explicit biases, but we all have implicit biases, which means we're not aware of them. So we all, as a healthcare industry, need to, number one, accept that it exists. And then number two is proactively challenge ourselves and saying, where does that come to play? And I just give you a few examples. If you are a Black mother in the United States, independent of where you live or your socioeconomic status, you have a 30 to 40% higher chance to have an adverse event to you or your baby during pregnancy and early childhood, the fourth quarter. That is well documented. There's no question about it. And if you're a Black man in the United States and you are way higher chance of being misdiagnosed for kidney disease or not diagnosed for kidney disease. That is because we calculated the glomerular refraction rate wrong. If you receive a pulse oximeter and you have a darker skin, your chances of getting a wrong reading are very high because these algorithms were developed on white skin. So that is real. That is not something which somebody is jumping on a vote bandwagon here. But we're not talking about it. And if we don't address health inequities, we will not fix patient safety. Full stop, end of story. So and I can go on with diagnostic errors, right? So diagnostic errors, if you are a minority, and this is not just race, this is, gender. This is if you belong to a certain minority from a religious perspective, from a sexual orientation perspective, if you're disabled, if you're a veteran. So that diversity, the inequities are prevalent throughout. And the first step is A, recognizing that they exist, and then B, being proactive and saying, okay, let's analyze where that happens. And how you can do this is you can look at your safety records. You can look at your adverse event records and say, okay, how many of those happen in minority groups? And you will be shocked. I promise you, you will be shocked to find on where you think this is equally distributed, it is not.
Marcus, you're raising such an important point here, which is, you've got to first recognize it. And then second, what you're getting at is measurement. And that's not something that we've, typically, and I'm thinking national level here, mandated. Now, it became an area of interest, certainly during the pandemic, and at least greater recognition that there were disparities when it came to access of care, right? And then access to certain treatments and or vaccination. What do you think that looks like in terms of actually measuring this going into the future? Or what do you think, either from a statutory standpoint or even just from the standpoint of managing a health system, should we be thinking about?
Well, that's the first step. If we measure it, we can do something about it. And if the saying in management, what matters get done. So if we start measuring it, we actually can implement change, and we can see if what we're implementing is actually working or if it's not working. Because not everything we're going to do is going to be the right answer for what the problem is, and that's okay. We don't have. ECRI doesn't have, or anybody really has, the silver bullet and says, oh, if you just do this, then it will going to fix it. It's very situational. It depends on where your healthcare system is. You're in a rural healthcare, in a rural setting, your problems are going to be very different as if you are in an urban or in a suburban setting, or if you're in California, or if you are in, Texas. So I think there's the situation, but accepting that inequities exist, and then identifying areas where they're most prevalent in your organization, and then setting up a plan, not here's the 50 things we're going to do different. No, take 3 and then implement the 3 and measure again. And once you see, well, out of the 3, 2 really work well, the third one not so well. So then let's go to the next 3, or let's take the next topic. And again, when we take this total system approach, which means leadership, patient and caregivers, plus the workforce with an agile learning system, you're going to come to a good solution. And then if you include the human factors approach in this and saying, okay, was the system designed with the human in mind? Because the human will fail. There's no question. The human will fail. And so how do we create enough redundancies into the system, and how do we design the system around the human in the center, be it the patient or the workforce or the healthcare provider, nurse, clinician, technician, whoever it is, and making sure that they have the best possible chance to succeed, rather than dumping them into the system and say, well, see how you can cope. It's a fundamental shift in how we think about delivering care.
Yeah, and in many ways, what we have to, though, when it comes to, when we talk about precision medicine, personalized medicine, and reaching people where they are, I mean, that's what you're really speaking to.
Steve, if I may say, I really want to make this good. Yes, the patient-centric approach is important, but the workforce, the people is actually supposed to function in the system, is equally important, right? We need to understand what are the inherent shortcomings. I mentioned to you earlier, right? The cognitive ability of dealing with 4 railroads. It's just one example. But I talk about this as these 2 systems who coexist. There's the medical system, and then there's the administrative system, who has to take care of all the things which need to happen to be able to deliver that care. And they are not necessarily conducive to each other. So how do we create these systems that they can better function? think about it as a clinical operating system. So on your phone, you have an operating system which makes all the apps talk to each other. Now think about this as a clinical operating system where all these different functions actually can function together. So those are some new concepts which have been proven to be very successful, not only in reducing patient harm, increasing patient satisfaction, increasing workforce satisfaction, and actually being financially profitable. So interesting concepts.
That's fascinating. And we are getting some questions in here, Marcus. So I'm going to turn to one of the audience questions, which I think is an interesting one. And interested on your take, between, the number, ECRI has been very much focused on devices and device safety. And when you think about, the past few years, respirators, syringes, I could name any number of other things that have had to be recalled. And it seems like at least the pace and number of these recalls has picked up in the last several years. Any sense of why that's happening? What should be done about it, if anything?
So the numbers don't quite support that feeling, right? So we have pretty much pretty steady amount of recalls throughout the systems. There was a slight uptick in 2023. The total impacted devices were actually less than in previous years. So I don't. Maybe we get more attention to it, which is actually good, right? So it's we talked about this earlier, that we maybe not getting enough attention to these things. In one in particular with the respirators in home, highlighted and we called this out I think last year and this year as well in our safety reporting, is that with the increased home use of devices, the industry and the regulators need to recognize that there need to be more effective ways in recalling these products. They cannot rely, like they do in a hospital, that there's a functioning supply chain with a good control of where those devices are, who's using them, how do we get them back. Even that is sometimes difficult. It doesn't exist for the home care. And this is something which the manufacturers need to fess up to. The regulator need to enforce it, but also the prescribers have a responsibility there in informing their patients adequately and saying, hey, when you have an incident, make sure that you reach out and we can help you recognize that. And so there need to be better mechanisms in place for particularly home use devices. and the devices which are going to be used in the home need to be developed for the home, which is another big issue. We can talk another hour about that. But that's a call out to industry as well, and saying, well, that your device, which is developed for a super user like an intensive care nurse, is now going to be used in a home by a layperson or some community nurse, which doesn't have the same experience or knowledge about this. And so now you're expecting somebody who usually drives a Ford or Prius to the hospital to drive a F1 race car, and that is not going to work. So that I think is important. And I've spent 20 years in industry developing products. So there's many things we can do as an industry to make sure that these products become safer, and we need to be more vigilant. And ECRI is taking that very serious, and through our network of our members, we often are able to alert the healthcare community about issues early on, and that is a very important task we have, and something we take very serious.
You're touching on I think a fundamental shift of what is occurring here and now, and really was accelerated. It was already happening pre-pandemic, but accelerated during the pandemic when it comes to the complexity of what we're providing in a home. We've got examples now in the industry of what we call advanced care at home, which is basically hospital-based services in the home. But But let's take it further than that, right? I mean, there's any number of skilled type services that are occurring in a home or increasingly complex care and skilled nursing facilities, long-term care facilities. I mean, there's a lot more going on than just the hospital itself. So much of the initial safety journey had been focused on, healthcare harm that was occurring in the hospital. There are a lot of other stakeholders now involved, when it comes to care in the home. And they don't all have an MD, PhD, or an MD after their name, or even a license after their name. So, Marcus, can you comment a little bit on that? What do we need to be thinking about as an industry in terms of what other stakeholders we need to get engaged? Um, how do we inculcate a culture of safety to a broader audience?
Yeah, that is probably one of the most discussed topics within equity. Is this we call it the shift of care areas. It's primary care is still going to be very important. A lot of the complex procedures like open cardiac vascular surgery, neurosurgery, polytrauma still will stay in the hospital. But more and more we see that shift into the ambulatory space, or very quickly from a very short stationary into the home. And then you mentioned, skilled nursing facilities, long-term care facilities. We have an aging population where higher demands on sophisticated care, because we're getting better in treating initial disease stages, and then complications or additional diseases happen. So that's getting much more complicated in a care setting which was not necessarily conceived as in high acuity care, but it's used as. And you're exactly right. We developed a lot of guidelines, a lot of best practices, a lot of regulation around the in-hospital care. And we made strides, not enough, as we discussed earlier. But now that care is shifting in an area which is highly unregulated. And that scares us. That scares us because we don't have the same understanding in those communities with these stakeholders on what risks they're taking on. And we're leaving them woefully unprepared to deal with that. This is not a ding on people who work in these facilities. We have just shifted a lot of the problems we had in the hospital into other care settings without equipping them adequately through training to all the things we discussed earlier: technology, training, clinical pathways, best practice guidelines, and so on and so on. And that has a tremendous risk, and we are very worried about it. What is it going to take? Well, to start with, it takes an informed consumer, patient. And the patient got to speak up. The caregiver's got to speak up and say, are you equipped to deal with my father, my mom, who needs a 24-hour infusion, who needs a ventilator assist, who needs whatever it is? Number one. Number two is then we need to, and I mentioned this earlier, manufacturers need to recognize that that is a very different user group. And so they need to design the equipment which is going to be used in these new environments to these new environments. And then we need to train the people who are going to use it or support it adequately. And we need to incentivize those facilities who are actually signing up for making sure that that these technologies are used appropriately and their staff is equipped and trained. So I don't believe in penalizing people. I believe in incentivizing people, because they're already having shortages from a staff perspective. If we now increase the complexity without equipping them appropriately through technology, training, guidelines, support, it will get even worse than it already is.
Marcus, there's another question that just came in that I think is an important one. And it reminds me of a conversation that I was having with another fellow leader at Kaiser Permanente. And here was the basic question that they asked me: is safety still a priority? That was the basic question. And it was in the context of a lot of other competing priorities, right? And so one of the things that has become important, and we touched on this earlier with some of our questions, is that membership and retention of our people is critically important. The workforce is critically important. And the attitude towards safety actually has significant impact on whether people stay or leave healthcare. Actually, I would sort of posit it probably pertains to almost any industry. If you're not feeling good about what you're doing on a day-to-day basis, you're going to leave. So here's the underlying question that they were asking, which is, can you talk a little bit about the importance of a speak-up culture, psychological safety within a team or within healthcare? And maybe from an equity perspective, are we doing enough? Do we need to be doing more? What's that look like?
So no, we're not doing enough, and we need to do more. This is where, when we talk about this total system safety approach, where the safety and the well-being and the comfort of that workforce is a critical component, if not in the center. And that's the same when we talk about this clinical operating system, where the person needs to be in the center, and the system needs to be designed around it with human engineering, human factor engineering understanding. That is exactly what we're talking about. And then on top of that, it needs the cultural aspects. It's a woke term, but if you think about what it comes down to, this culture of belonging is, if we can, as leaders, can create a culture where people are comfortable and they feel they belong, because they're respected of who they are, because they are respected for what they bring to the table, and because they are feeling safe in speaking up, even if their voice is the outlier, and are at least get the sense they got to be listened to and taken into consideration. That's the true meaning of inclusion. Not having, different race and gender sitting around the table. That's not inclusion. Inclusion is if everybody can be their best self the way they are and feeling comfortable. That's the concept of culture of belonging. So it is up to the leaders in healthcare, in the delivery area, in the administrative area, to create a safe workplace where people can show up their self best. And then there's tons of literature which provides that if you are able to create that environment, you will have higher work productivity, lesser turnover, more innovation, better outcomes. So there's no reason not to do it. There's simply no reason not to do it. And this old culture of blame and shame and fear and punishment and so on, it's a thing of the past.
Marcus, that is a great answer. Okay, I saved the best for last. I got a hard question for you. Okay, so this came in here, and I've had to reflect on this myself too, as a safety leader. So we've talked about the concept of zero harm for a long time, and getting to zero harm. And I'll sort of paraphrase a little bit of our previous conversation: zero preventable harm. Is that possible? Number one, and if we think that is possible, what's it going to take to reach it?
I wouldn't be here if I don't think it's possible. Right? I haven't given up on that. I know we have a long way to go, and maybe I'm not going to see it during my active time. But that's what gets me out of bed. This is what makes me excited. That's where my passion is. As I mentioned before, we swore an oath. We shall do no harm. So let's aim for that. Let's not accept anything less. Let's not be okay with, yeah, there's going to be some, collateral damage. No, it starts with ourselves. It starts with the mindset we have. And if we say, no, we're not going to do this, then everything we do in our daily practice is going to be measured against that North Star. And I speak for myself. Have I taken shortcuts in my physician life? Absolutely. Had I had the same thinking as I have today, that would have been much less likely. So it starts with that general acceptance that is achievable, and that is something which we all sign up for. And this is the other thing that, again, which is you can't do this alone. We can do that for one area. We can start there, but at the end of the day, it's going to take that systematic approach. And I'm sounding like a broken record, I'm sorry, but it takes these 4 aspects, and it's proven over and over again. Leadership and culture, patient and their caregivers, agile learning system, and a safe workforce environment. Those are those 4 critical essentials, and combine that with taking the workforce in the center and creating a clinical operating system around it, which allows them to practice safely and allows them to call it out when it's not happening. And those are the key ingredients. It's not rocket science, but it's hard. And we've got to start somewhere, and then we start developing from there. When people hear me talk about total system safety, they say, oh, the whole hospital needs to change all at once. No, you can start in a ward. You can start in a department. You can start in one OR. It doesn't matter where you start, but you got to start. Because then you're quickly going to see the benefits and the positive effects, and others will latch onto it.
I really think this is a great way to tie it up, because what you're describing is systematic optimism. We have to continue to push. If you were referencing the OR, if we had sort of said retain foreign objects is just something that we have to put up with, and it's a cost of doing business, we would have made no progress. And yet Absolutely. There's been massive progress. And I could cite any number. It warms my heart, Marcus, as an infectious disease physician, to know that we've had a lot less HAIs in the last decade than we did before. So it's a journey, as you reference. So thank you so much for joining us. Thank you to everyone who joined this webinar and watched. Based on what we know from all the research out there and from Dr. Schabacher's remarks, we've got work to do to continue to improve upon our basis and our belief in patient safety. And while technology, AI, value-based care are all good, exciting, interesting, it's us. It's us as clinicians that ensure that we are the foundation for which patient safety emanates. Ensuring that patients remain safe is one of our most basic obligations as physicians and as clinicians. And using that technology to our advantage, innovating beyond it, that's really what we're all about. And despite the scale of the issue before us, many hands make light work. And Dr. Schabacher, thank you, and ECRI for all of the contributions to healthcare to improve patient safety. Thank you all for joining us today. And I hope you all have a good rest of the week.
Thank you, Steve.
Thank you.